again for being here, and first to start I have to apologize my voice. I came with a bad Bavarian flu here and my voice was going away, and yesterday evening I thought I should drink some Ukrainian vodka. I had the normal vodka, I had the honey vodka, then I said okay, I have to take the honey plus red pepper. At the end, it was a nice evening, but my voice is even worse. So sorry for this. I've got two lectures in this session, and the first will be about general aspects of surgery in pancreatic cancer, to give you an overview with all the problems we face within our operations. And on the next talk, later on, I will just focus on the oncological parts, what we have to consider when we do pancreatic surgery in pancreatic cancer. Now, I've got the same problem. Okay, now it's working. So, it's one of the big questions we always have when we have got patients with jaundice is whether we want to stand or not stand, and if this is the correct question at all, to stand the patients or not. And we have in parts of individualized therapy in pancreatic cancer, we have got this situation where we have to face these kind of patients with malignant jaundice, and it's nearly about 50% of the patients we see for this disease. So then always the question is, do we go for primary resection or should we go for drainage? And now, I think all of you know this paper that the preoperative biliary drainage for cancer of the head of the pancreas, shown by the group of Van der Gaag, was associated with high complications when you do a PVD. So the preoperative stenting increases the rate of complications, clearly. And what we have done, and now a systematic meta-analysis at the moment under review of my group, and could again demonstrate that the PVD is really associated with overall complications rates. But the problem is, evidence is clear, but what we face in everyday practice, still too many patients receive a PVD. This is what we see. And I think this is the same in Germany as in the Ukraine or elsewhere. We know that this situation has got a lot of problems for the patients. We have got increased wound infections especially. So we have got have to face a lot of antibiotics. And we have certain kind of germs which we identified as risk factors during a PVD, which is developing then or was more associated with wound infections. And when you do a targeted therapy of these patients, then you reduce the severity of the complications and also reduce the wound infections. But still, actually, we don't know, and I want to show you a study which we just finalized. We actually do not know what is the biliary microbiome when we do stenting in these patients. What does it change? And when we do this, do we use the correct antibiotics? And what's the impact of this biliary microbiome for our patients? And who are our real enemy germs? We just don't know in depth. For this, we did a monocenter study within our department, and we only could include these patients where we had already biliary biosamples during the operations, and then analyzed the microbiome and also test the sensitivity of the antibiotics and looked for the postoperative outcome. And what was interesting is that 20% of all patients who has no stent had also a biliary microbiome which was evident. It was not surprising that with stent, nearly 100% of all the patients has got a certain microbiome. But what was even more interesting is that when you compare these patients who had a microbiome, that the the shift, the microbe is completely different. So when you have no PBD, you have got a E. coli germ about 50% versus with PBD to 20%. Whereas within the patients who has got no PBD, germs like Enterococcus faecalis, Faecium, or Cloacae were not important germs because they were hardly there. But this dramatically changed when the patients got a PBD. So this means the microbiome, there's a completely shift, and it's completely different. And what does it affect on the antibiotics? And this is a major effect, because when we have no PBD, we have a resistance to what we use, I think all of you quite often, ampicillin, sulbactam, about 18%, which is dramatically increasing up to 60. And piperacillin, tazobactam, or ciprofloxacin are also what we all use, I think. And here quite good indications when the patient has got no drain, but suddenly increases up to 3 times, up to 30%. So this is a major effect, what we can see here. And these effects clearly also what has been shown in the former meta-analysis, we could reproduce this in our group also, that when you have got a positive bile, then the wound healing disorder, the wound infections are at risk, whereas the other comorbidities were not so important whether you have a drain or not, a stand or not. So to conclude from this is that the biliary microbiome of patients with or without stand are fundamentally different, and so we have to make individual therapy regimes for these patients. And perioperative antibiotic treatment has not to be given blindly. It has to be given in a differentiated manner regarding whether the patient has a stand or not. The further dilemma staying this focus is it's actually at the moment not a question whether to stand or not. We know that we should not stand, but sometimes the patients cannot achieve the surgeon soon, or due to other reasons the operation cannot be done as fast as possible. So then we have to also consider whether to stand this patient or not. And actually we don't know when the patient comes to you and has got a bilirubin over 10, and then do you say, okay, should I operate this patient? Is over 10 too much or not? We actually do not know. We just from the gut feeling say, oh, okay, over 10, 18, maybe we should go for stand for the moment and operate him later. Or should we go have an eye on the leukocytes for the cholangitis and then decide what to do? Or even liver function, like prothrombin time, or even maybe like in the liver transplantation, look for the MAD score and see whether this gives us an image about the liver function at the moment of the patient. And when already the patient has got a PBD, a stand, a drainage, and was not coming and is coming to you to get operated, when do you operate this patient? After 1 week, 2 weeks, 3 weeks, 4 weeks after stand? What is the optimal time? We don't know. So for that reason, we looked also retrospective in our collective and try to identify parameters where you could stratify the patients at risk to have complications. And we use for this the Clavian-Dindo classification, above 3 and below 3. And what we could see that the bilirubin, doesn't matter how high it was not important at all. The leukocytes was not important at all. The MELD score was giving a picture of the liver function, was not important at all. What was important at all was the prothrombin time and the ENR. This was the only thing where we could identify patients at more risk to develop complications. And when we looked at the patients who had a stent, again, bilirubin levels were not important. So it doesn't matter whether the patient has got 10, 11, or 20, it was not affecting the comorbidity of the patient after the operation. Here it was clearly the patients who had cholangitis were the patients who were at risk. And once the stent is inside, waiting how long? So we looked, when did the patients get the operations? Below 2 weeks, 2 to 3 weeks, 3 to 4 weeks, then you can see that you have a real high Clavian-Dindel scores for 4 and 5 grade within these patients. But when you looked later on, so the patients who had stents 4 to 7 weeks or more than 7 weeks, then the patient did better. And they did not develop such kind of complications. I mean, when we as a surgeon has got the patient with a stent, so from the gut feeling to wait 4 weeks is a hard time. And the thing what we all ask is, do the patients do not get better because the survival decreases of the patients and the tumor is exploding? But it was not the case. So when you look at these patients, the blue with no stents, and the other one, the red, below 4 weeks, green, above 4 weeks, all the same. So waiting is getting for the comorbidity for the patient better, but has no disadvantage regarding survival. The take-home message of this passage, I just want to show you that you should not look at the bilirubin. It's not a predictor of outcome. And it's not a predictor and not a parameter which you should or can use whether to stand or not to stand the patients. Cholangitis maybe where you clearly see that you should not go for primary resection and do the stenting. And the newer results, when you have no cholangitis, then you should look and prefer the NR and to see whether the patient should get a stent or not. And if the stent is in situ and the patient comes to you, just consider to wait longer to have less comorbidities. Now, coming to another very important point is we all fear the pancreatic fistula. And is it always a good idea to predict or to see or identify the patients at risk who will develop postoperative pancreatic fistula after my operation? And with this very elegant study now published last year from Turkey, they identified the 80 patients with a Whipple operation, and they made an analysis of just every CT scan which every patient has on native CTs. And they used Hounsfield units to identify the amount of fatty tissue in the pancreas and compared it to an organ which has got no fat at all, and this was the spleen. And they somehow developed the pancreatic attenuation index and try to identify maybe patients at risk who will develop pancreatic fistula. And what they could see, that the patients with a lower score had with a higher score of the index had a very few rates of fistula, so less fat, less fistula. But the patients at higher risk with more fatty tissue, also more fatty pancreas, the rate of fistula was up to 30. So this could be a tool which is very easy to be done during routine daily practice to predict patients who will maybe develop postoperative pancreatic fistula. A similar study was also recently published, and they analyzed preoperative analysis also of CT, and they somehow tried to get the pancreatic remnant volume, whether this is also affecting the persistence or the generation of pancreatic fistula after the operation. And the risk factors which were identified were actually the pancreas texture, the soft tissue, which the surgeon said whether it is soft or not, but also within their analysis with the computer tomography that the remnant pancreatic volume does matter when you regard the genesis of pancreatic fistula. And this was explained by the fact that the more the volume is clearly what happens, the more the juice is there. So there's more amylase production, and there's more amylase in the drains of the patients who have got more volume. So this means when we have a more remnant volume, then we have, of course, logically, more pancreatic juice and also amylase in the drains. And when we do the resection, also regarding the fistula, is there a preferred reconstruction method after pancreatic? And there was a recent meta-analysis whether to go for pancreatic jejunostomy or pancreatic gastrostomy. And here over 1,000 patients were analyzed, and it was clear that here the pancreatic gastrostomy decreased the incidence of pancreatic biliary fistula during this meta-analysis. And although the pancreas is in the gastric area, there was no changes in delayed gastric emptying or overall morbidity, and even decreased the length of hospital stay. Professor Keck Tobias has just mentioned his study, which was just recently published this year in Annals of Surgery, a great study with multi-center, randomized control study, 14 high-volume centers in entire Germany, over 300 Whipple operations, and also here the clinical primary endpoint was the clinical evident pancreatic fistula. Here it was the case that not, as he has shown you before, no difference was in the pancreatic fistula regarding whether you do a jejunostomy, anastomosis, or gastrostomy anastomosis, but slightly increased postoperative bleeding in the pancreatic gastrostomy. Why ever, I have no explanation. Maybe you have more strokes. I think this is just a coincidence. But in regards of the success, it's similar. So this means when you do a Whipple's operation and you have to ask yourself what kind of reconstruction are used, use the one you feel safe, because both are safe and you have to feel comfortable. And then when you want to put it in the jejunum, put it in the jejunum or in the or in the gastric. So when we have done the resections, should we use drains or not? Is it our friend or is it our foe? And here is a meta-analysis published 2013. It was clear that the patients without drain showed the lowest complication rates in this meta-analysis. But there are also other publications, especially this one. This was a good planned randomized control trial, over 130 patients comparing drain and no drain. And what was happened that the patients after 30 or 60 days, the patients with drain and no drain, when you compare them, the patients with no drain had higher kind of complications with significant differences regarding gastroparesis, intra-abdominal abscesses, diarrhea, and abdominal fluid collection. So that the group without drain had more morbidities, had prolonged hospital stay, increased additional interventional drains, and significant mortality increase, even 3 versus 12, so that the study monitoring board canceled the trial ahead of the finalization. Why is also the drainage important? Because when we want to identify the patients with the fistula grade, also according to Bassi, here also a very excellent study. They measured daily amylase concentration in drain fluid, and it was the primary endpoint was the perioperative complications. And what they could identify was when the amylase drainage content of amylase was below or over 600 units of amylase, it was clearly associated with morbidity, in terms of pancreatic fistula, and could identify these patients having a risk to have higher pancreatic fistula rates during only one-time measurement. And I think this is a good message, because when you're afraid of the drain and you're looking of the amylase of the first day and then can decide whether you can get rid of the drain fast or slow, this could be an elegant method to have a good decision pathway. And on my last section of my talk is, when you do the pancreatic left resection, it's always how do you close the remnant. This is a matter of debate, which is very long. So we have got many techniques of pancreas transection, this is a pancreatectomy. And this is a wide variation. And actually, what is the problem is we actually do not know what is maybe the best. What we have done is also not submitted now, a meta-analysis comparing all kinds of these techniques. And when you compare these, we have identified over 4,000 patients and looked first at stapler versus hand-sewn suture. It was clear that the stapler was superior to suture. And when you then compare, even some people also use stapler and then they suture over the stapler versus stapler alone. There was actually no difference. But again, when you do the stapler and the suture versus only suture, then again there was a significant benefit of the stapler alone and also in combination with suturing. And then there's also groups which are doing anastomosis even when you do a left resection on the remnant. And comparing this with the suture, always the anastomosis is better than the suture, but again, stapler seems to be a very good option because the anastomosis was not being able to demonstrate to be superior when you do only the stapler alone. So there are now a lot of randomized controlled trials on this subject. So we are eager to find out whether there will be more identification of new techniques, especially also the ligament falciform patch, seam guard, which you also shown here with the nice video of Professor Keck, and tissue link, tachytom, and also hemopatch. These are new bioabsorbable materials which will also are in investigation. So I think the next years we will get to know again more on this topic. So far, thank you for your attention. I'm open for your questions.
Thank you, Professor. Some questions? Please, Marco.
Yes, I start from the end. Actually, we completed right now a prospective randomized trial using biomaterial to cover stapler versus stapler alone, and we found a significant advantage. So we are going to publish the paper very soon.
Which?
That's, I mean, I don't remember even the name of the company, but anyway, I don't want to even make a publicity. But I mean, there was, it's not the same that you mentioned there, and so we will publish, I think, very soon. There will be also the APC, I think, a presentation on that. I have a couple of consideration. The first one is on the stent. I think the stent is quite clear that we should not put a stent. On the other hand, I have to say, I realize in Sweden it's very common to have patients that arrive to you with a stent, and one of the reasons is centralization, a very strong centralization. So stent and centralization are actually going together. As much more you centralize, much more you stent. So it's very difficult combination. We saw before, volume is very important. To make volume, you need to increase waiting list generally, and you need stent. I agree with you, we have the same experience regarding the parameter to predict outcome. So basically liver function in terms of coagulation. We have the same experience. I just want to say one thing regarding stent. Sometimes bilirubin is important after stenting. You can discriminate the patient that has a liver problem because bilirubin doesn't go down after stenting. That sometimes to have a stent is good because you can select those kind of patient. So my question was for you, what do you think if you should choose between stent or centralization? Because that's, I think, sometimes is a real critical point.
Thank you for your very long comment and short question. I think you are completely right. I think it's a good side effect of the centralization that when you have got more stent. This is something which I could live with. But I think in your country, in Sweden, it's like the case. I mean, so you're operating, I don't know, more than half of all, or even more, of all these cancers at your institute, and similar maybe in Netherlands. But this is not. Should be the golden goal, I would say, but it's not widespread. Until we don't have this golden goal in other countries, also it's in Germany, you have the possibility to to send the patients to, let's say, high volume centers or even excellence centers. Then you should go for not stenting. But depending, on your country, then I would understand this and say, okay, this is something which you cannot avoid, because you cannot operate them all immediately. So there are too many, I think, for you.
Very nice presentation, thank you very much. It's interesting and striking, I think, were your data on the bacteria and the stent. We have now worked over our experience with stents and found that if you do not stent and you have a portal vein resection and you have some limitations in liver function previously, then you can get a really in big trouble post-operatively. And we have a collective of maybe 15 patients that had from moderate to very severe liver dysfunction after resection combination, no stent, elevated bilirubin, which might not play a role. We have to look at the maybe prothrombin time, and the combination with portal vein resection. Do you see something like that? Do you or Marco, do you see the same?
I mean, this is a very good idea. I mean, we didn't look at that in this collective. Actually, I have to admit, I even do not know how many portal resections are in this group. So, but this is a good idea to make a subgroup on this. But I don't know, because I didn't check. Sorry.
Спасибо. Так, последний, last question. И, пожалуйста, коротко.
For the nice talk. Very short, 3 questions. The first one is, how many patients with bilirubin over 200 micrograms per milliliter did you operate? The first question. The second one, what kind of closing of pancreatic stump do you use now? And what kind of anastomosis after Whipple do you use now? Thank you very much.
Coming to the last question, I mean, this is just, I come from the Bega Büchler school. For that reason, we go for the pancreatic jejunostomy. But maybe, let's say, when I do the operations, it is a very soft tissue, the soft pancreatic tissue, then I sometimes go for pancreatic gastrostomy, but this is really, really rare. Let's say when you do 100, it's maybe 2 to 3, so we are on the pancreatic jejunostomy still. And the first question is, I think this is, I have to say, around the number about 15% maybe who have got such high numbers of bilirubin, and we did not face that these patients do less well. So this, I think this really does not matter. And the second question was?
What kind of closing of the stump?
Okay. We still do, although the evidence is better for stapler. When I do the left resections, laparoscopy, of course, then I do a stent, stapler. But in the open, usually we do Hansun. And what I mean, I didn't show the data, is what we actually do. We are selectively suturing the duct and then the stump, and this combination is much better than only Hansun. So for that reason, this may be a special group of Hansun patients.
Thank you very much. Just a moment, Professor. Are you ready to do next report? Your report? No? Okay. Please.
I hope my voice will not die, but so now coming for extended pancreatic surgery. So what's the benefit? I mean, when I started in pancreatic cancer research, it was really a bit frustrating, but this figure shows you that something happens now. And when you see the incidence of cancer is gradually increasing, and also the incidence of pancreatic cancer is even increasing more. And one of, maybe of course, the reasons is that our patients get older because the medicine is so good. So we have to face more and more older patients. And when I just started here around 2000 with my research in pancreas, this figure was really frustrating. So the incidence was equal to the death of the patient, so that means everybody dies. I mean, still we have got this situation. But when you see these figures, we are somehow better now. So this means we are doing something correct at the moment. And I think we are developing to a good way so that we can really help these patients more than we could do it maybe 20 years ago. And one of the things which I think this is not, I think there's no discussion on this, is that the curative resection is the single most important factor determining the survival of our patients. So, but what determines the outcome? What is limiting our curative resection, or may limit our curative resection? Is it the vessel, is it perinodal infiltration, lymph nodes, R status, metastasis? What are the real prognostic factors? I mean, there are some solved questions. When we do the resection, whether to go for classical Whipple or preserving Whipple does not matter. They are both good. There is no differences in survival. Thank you. And is it so bad? So, and whether you do a standard or extended lymph node dissection, it doesn't matter. I mean, there's no difference in morbidity and mortality, and then there's no difference. You can avoid to do extensively lymph node dissection. The adjuvant treatment, we know that when we do the resections, our patients do better and have better prognosis when they get 5-FU or gemcitabine after the operation. These are the things which are, I think, really solved, and we know this. And now, still open questions are for radical surgery. Does age matter? Venous resections, we discussed about this already. The artery resection, the extended multivisceral resection, R status, and, which is, I think, very, very attractive at the moment, the impact of neoadjuvant regimes. And I will just talk on these topics. I mean, what we know from the studies we have so far is that the age is really no contraindication against resection. Here, Adam has investigated patients below and up 70 years, and they could show that the overall complication rate was not significantly increased. But the patient had postoperative mortality was higher in the patients who were older, and I don't know why, also the pancreatic fistula. But when you again, although there is an increased mortality, the overall survival of these patients was not different. So when you operate the old or the younger, the survival after adenocarcinoma remains the same. And when you, even in these patients, another study, also the cutoff was 70 years, do even a portal vein resection, there's no single hint that there is a problem with mortality, morbidity, postoperative outcome of these patients, whether you resect portal vein below or up the age of 70. But what does matter in these patients is the comorbidities the patients already have and bring it to the operation. And when you have cardiac complications of these patients, whether chronic or acute, these patients have a higher mortality and morbidity. So we should not, when someone is 80 or 85, just be feared to operate these patients, because 85 is not 85. So we are not operating figures, we are operating patients. And for that reason, we have to make individual decisions in these patients whether this patient is fit to go for surgery or not. Coming to the venous infiltrations and resection of the venous part. I mean, when you go in this randomized control, it was very well demonstrated that when you go for resection, you have a 2-year survival of 80%, a 5-year survival of nearly 20%. And when you do the bypass, because only of venous infiltration, so there is no survival. So then for this, I think this is something which is clear at the moment, is if you have the possibility to go for venous resection, go for it and avoid bypass, because you will not help your patient. And then you can't do the venous resection, don't operate the patient and send it where the patient can be operated. And when we look on the survival and outcome of these patients with venous resection, then you can see with the patients who have venous infiltrations, there's no contraindication for resection, because there is no difference between mortality and morbidity when you do a resection with venous recursion or without, as in patients with venous infiltration and without. So, but when you would have not operated patients with venous infiltration, then these figures would be completely different. Here, also a nice, elegant study. They investigated whether the patients have venous infiltration or not. There was no difference in R0 resection, and there was also nearly the same effect which I just talked recently, on disease-free survival or overall survival. But this is the benefit of the resection. Again, when you do not do the resection, these figures would be not like this. So there is a need, in my eyes, for the redefinition of borderline resectable pancreatic cancer. The borderline resectable pancreatic cancer can be applied for arterial implication, but not for the venous. So here in this meta-analysis, there were also about 3,000 patients investigated. There was no difference in perioperative morbidity, mortality, or 1 or 3 year survival. So the only thing was, what did matter was, when you have a resection, you should go always, of course, for R0 resection, because this was the only thing which had an implication in this group. So when you just combine all this data, it's clear that comorbidity but not age matters. And when you've got an infiltration of the portal vein or SMV, this is no contraindications for radical surgery. And venous R0 resection is essential, and you have to go extendedly. You have venous resection, end-to-end anastomosis or graft interposition. You can hold these kinds. And as I told you, venous infiltration is not a criteria for borderline resectable pancreatic cancer. The arterial infiltration, there, Marco and me, we are very good friends. I'm a little bit cautious on this, because to obtain R0, we have to have retroperitoneal margin be free. And the problem is that within this, we have still up to 88% invasion of the retroperitoneal nerve plexus, nodal invasion, and also even macroscopic arterial invasions up to 44%. And what we do know from good studies, that we are all good surgeons, and Marcus especially, a very good surgeon regarding also reconstruction of the vessels. This is not a technical issue. We can do that. But the problem is we have a high reoperation rate, the morbidity is increased, and the mortality is increased within these patients when we go for arterial resection. And at the end, the mortality is really throughout different studies, one of the things which is really high with the patients who go for arterial resection. We give them more morbidity and mortality, but we are not giving them any advantage on survival. The arterial infiltration has clearly at the moment impaired perioperative outcome with the data we have so far. It has higher association with morbidity and mortality and no survival benefit. The thing what maybe will change in the future is what does the neoadjuvant regime have an effect on this, because this we don't know. And I think there I agree with Marco, there we should try. But maybe also the newer neoadjuvant treatments will bring us to a situation where we will not need arterial resection to get the artery free of the tumor. But I think this is something we will learn this in the near future. The infiltrating of neighboring organs should be no contraindication. Here, a very good study of Professor Hartwig, who was at that time still in Heidelberg, now in Munich, about patients, 100 patients with multivisceral resections compared with 200 standard resections. What was evident that the obliteration, blood loss, morbidity, and mortality not mortality, but morbidity was increased in this group, but the mortality was the same. And what was here very interesting, and I think this again, this story with the venous resection, yes or no, is that the survival was completely equal. But when you would have, due to the infiltration of neighboring organs, have not resected the patients, again, this curve would be different. So for that reason, if you can do this, and it's technically feasible, do not fear a multivisceral resection also for pancreatic cancer. So the impact of the R status, and I think this is, a very still ongoing debate and issue in pancreatic cancer. And also, we have got the problem, Professor Keck was wondering about the wonderful 90% R0 rates of Professor Kendrick compared to his, I think it was 60. So I mean, this is for me, this is clear why it's this situation. Because in the USA and in Europe, there are different definitions of R0. So we are talking also in international congresses on R0 and R1, but the problem is that in the United States, when you have a definitive positive resection margins, only when the tumor cells are present at the edges of the operative specimen. So this is, let's say, a more soft version of R0. But we here in Europe, we are defining a positive resection margin if the tumor cells are less than 1 millimeter from the margin. And I think this pictures maybe show you or demonstrated the problem. When you see this edges here, a nerve close to the edge with massive infiltration of carcinoma cells or even cancer cells just at the edge. This situation is in the USA R0 and in Europe it's R1. And when you, as Professor Esposito very well demonstrated, re-examine the patients with standard protocol, suddenly the patients who were nearly 80% R0 become 14% R0. So this means we have got this situation that we really cannot compare R0 and R1 and also the success of this when you regard the US and Europe. And we have an even more problem, and I want to show you this in this case, this is a patient with a common with a pancreatic cancer. You can here see very well the tumor invasion front, and what you can see here at the cerebral trunk and here the common hepatic artery, I always call that to my students some kind of cloudy stuff. So this area, because you don't see any infiltration of the primary tumor in that area, but you still see some cloudy tissue. And when you look at that on the microscope, what you see there, this is the massive invasion of neural invasion of cancer cells. And this is the problem with really limits our curative resection, because you cannot get rid of all that tissue always, because it isn't the nerves, there will be the remnant tumors. And as a very, I love pancreatic surgery, but I have to admit, I don't think that we have R0 resections in pancreatic cancer due to this problem. So, I mean, the debate in pancreatic cancer about R0 and R1 is debatable, because I don't think that we really have always when there's an R0, a R0, doesn't matter whether it's Europe R0 or USA R0, due to this situation. It really limits the curative resection of the patient. I think it's more important to get rid of the tumor, but the microscopical achievement of our surgery is limited due to neural invasion. And there are, due to this, also different publications who really say whether you have R1 status below 0.5, 1 millimeter or whatever has no impact on progression and free survival. There are other publications who just demonstrate the opposite. And so the problem is that it's a resection man after pancreatic cancer still under, as I show you, also due to the reason, under controversial debate. And is R0 or R1 even doesn't matter in pancreatic cancer due to neural invasion is another debate. So for that reason, I think we have to work on what really R0 and R1 gives us for information regarding pancreatic cancer surgery alone. So when I summarize for this passage before coming to the neoadjuvant treatment is, when we want to resect the old, yes, we should do what we should do, make individual decisions. Venous resection, clearly yes. Arterial resection, to the knowledge of evidence at the moment, definitely not. Extended resection, we should go, but still, this is some kind of individual resection. And R1, R0 resection, I think this is what I add in the last sentences. Now, the reality in pancreatic cancer is that we have somehow the highest 20% of patients who are really directly primary resectable. And these patients are the ones which are very, very attractive at the moment, because these are the patients maybe formerly not classified as resectable, but what you call locally advanced. And these are the patients who we can maybe get more from with neoadjuvant regimes. This is a recent meta-analysis who have identified several studies with over 250 patients who had FOLFIRINOX with or without radiotherapy, and then prior to surgery in patients with borderline resectable or unresectable pancreatic cancer. And still in these patients, which we could, where we said that they are not actually resectable, 43 were resectable, and the R0 rate in general was 40%. And if you go for the patients and classify, which we have classified borderline resectable patients, R0 resection was achieved in 63% of these patients, a high number. And the patients which we classified already non-resectable, still, although their R0 resection after neoadjuvant therapy was able in over 20%. So we have somehow a noticeable downstaging after neoadjuvant FOLFIRINOX therapy in patients with borderline or unresectable pancreatic cancer. I want to demonstrate this in a case which we treated in our department. This is a 67-year-old patient, a female, very nice lady, had a locally advanced pancreatic cancer. And we decided to go for neoadjuvant treatment. I want to show you the CT scan of these patients prior to the operation. Here you can see also already the celiac trunk with also here massive infiltration of pancreatic cancer. This is the celiac trunk. You can see the splenic artery coming out, but still a mass of tumor within this lady. And this is the greatest portion of the tumor. And it has got even contact to the mesenteric artery axis. Now, what we said, this lady should go for on a trial. This is the so-called NeoLock trial, where the patients get a certain regime with gemcitabine, nab-paclitaxel, and FOLFIRINOX. And after this, doesn't matter what we see in the CT scan, they have to go to an exploration and see whether you can resect the patient or not. After the treatment, we also did a CT scan. And when you see this is the same patient, and you see then the involvement of the cancer, one would say, sorry, no effect. There was no tumor, no reduction of the tumor. The tumor is as present as before the neoadjuvant treatment. So what we did with this patient, we explored the patients And what we could do was, we did an oncological pancreatic left resection, splenectomy, resection of the left adrenal gland, partial resection of the portal vein, and a cholecystectomy. And this was the intraoperative finding. This is the left adrenal vein, this is the artery, the AMS, here's the aorta, here's the celiac trunk, hepatic artery, and we could get rid of this tumor. Here, the resection of the portal vein. And in the pathology, it was a T3 tumor with no lymph nodes, perineural invasion, and we said it RX because, as also my friend Marco told, what we in the frozen section always got, because we, in such cases, we do always frozen sections when we have the suspicious finding, and go further, and then decide when there is a real massive tumor, then we stop the operation when we can stop it at that time point, which we usually plan so that we can do this. And in this case, there were only single cancer cells. Because I can remember this, because the lady, the pathologist told me, Guralp, these are 3 or 4 cells which I can see, but the rest is just dysplasia. So do you stop operating? May you have such a finding? We did not. There are also, regarding this, really nice publication also from the Boston group last year, published in Annals of Surgery, with nearly similar in the finding, which we also see in everyday routine, is that we have got this tumor, and this patient has got on the right hand side pre-fulfillinox and after fulfillinox with nearly the same appearance, and in the final pathology also it looks the same. There was no viable tumor in this case, in this publication, and again, as in our case, no lymph nodes. So this means that we have to learn, and we have to really learn from the beginning somehow. So it's very exciting time for us pancreatic surgeons. That imaging is no longer the right tool to predict the unresectability of these patients, and that we actually cannot distinguish between desmoplasia and viable cancer in these patients. For that reason, we have to go another way, and because we have to avoid to say unnecessary always, there's no response, the patient is lost. We should explore the patient, and we have to try, and we have to learn, because this is an era which is just now opened with the neoadjuvant regimes, and we must learn, try, and increase our experiences with this new situation. There's also on this debate a lot of ongoing clinical trials regarding resectable and borderline resectable pancreatic cancer. So I hope that in the future we will be also much more experienced regarding this. Thank you for your attention. I am open for questions.
Thank you very much. Only one short question. Only one. No, please.
Thank you very much for fantastic talk. And the question is, do we have by far the long-term results of such kind of patients which have no changes after neoadjuvant therapy and was successfully treated with such a brilliant pathology?
To my knowledge, we don't have at the moment, but I think you have the survival data of these patients which are so far doing good, and no changes between the patients who had not neoadjuvant treatment and had directly resection of the tumor. We did not investigate it within our department because I mean we are still in a learning curve. Let's say what is this concerns. So for the best of my knowledge, I don't know whether this particular patient group has gotten analysis. I don't know whether you both know, but I don't know.